we'll go ahead to the second speaker. I would like to introduce my colleague, my co-chairman, Dr. Nabil Al-Najjar, who is known in the Jeddah community, very interested in diabetes.
Thank you, Professor Hamid. It's my honor and privilege to co-chair this session. I would like to present Professor Husam Junaid. He's a consultant of internal medicine in King Faisal Specialist Hospital in Riyadh. And he's going to present about hypertension and obesity. These are twin diseases that come together, and I would like to hear from you. Please.
Thank you. Thank you, Mr. Chairman. I would like to thank the organizing committee for inviting me and giving me this opportunity. Good morning, everybody. I will speak today about obesity and hypertension. So initially when I was asked by the scientific committee about this, I said this is like really a simple topic that they gave me. Okay. However, when I searched the literature, I found a lot of things that needs to be talked about. So I'm going to try to be just direct and summarizing things and not going into much details. So I will go over a few things about obesity and epidemiology and about hypertension, and then the relationship between both of them, and then about the metabolic syndrome, which is related to both of them, pathogenesis, and a few words about management of obesity-related hypertension. So this is an old, very old slide, actually, before the, the invention of the iPads and all the electronic games, at the days of the TV. When, I mean, nowadays, and even in the last few decades, there has been really an epidemic of obesity related to two main factors all across the globe, which are sedentary lifestyle and overeating. And last night we enjoyed actually the dinner in a nice restaurant, Italian restaurant. Dr. Ashrafa invited us and took us there, SHMS, and it was very nice food. It's very difficult for me, it was very difficult to resist eating and overeating with all high carb diet that was. And this is not an this is an example of how really even people who know about diet and conscious about diet, but sometimes when you see the nice food, you cannot resist. Even though it wasn't like kebsa and you know, the rice, but there was a lot of carbohydrate there. With right. Next time we'll go with kebsa, right? So this is really the two main problems that we have. Obesity is excessive weight that may impair health. And it can be defined by knowing the BMI, the body mass index. And the normal for the body mass index is less than 18.5. Sorry, the underweight is less than 18.5. The normal weight is 18.5 to 24.9. The overweight is 25 to 29.9. And then you have the obesity when it's like between 30 to 34.9, which is obesity grade 1. Then grade 2, and then the morbid obesity, which is more than 40. My voice is clear, right? So over the last really 4 decades, the numbers has tripled or quadrupled of overweight and obesity. In 1975, overweight population was 20% in men and 23% in women, whereas in 2016 it became as 39% for adults. And for obese it was like only 3 to 6%, and now it's around 15%. We have around 2 billion adults across the globe who are overweight, and 0.5 billion Is it better? Ah, much better now. Okay. كان هذا ما أحطها شوية. بس شيل هذه. خلاص. شكرا. So we have around 2 billion adults worldwide Is it good or it has to be? No. 2 billion adults worldwide who are overweight and 0.5 billion who are obese, which is a huge number of like 7 billion. And what about our region, or the Eastern Mediterranean region? The highest obesity rate is found in Egypt, Bahrain, Jordan, Kuwait, Saudi Arabia, and United Arab Emirates. Actually, the obesity and overweight rate ranges between 74 to 86%, and it's more common in women for obesity and more common for men for overweight. And it's increasing among children, unfortunately. Why do we care about obesity? Because it has a lot of complications, many medical complications. It has to do with the stroke, with coronary heart disease, and it comes with other comorbidities like diabetes, dyslipidemia, hypertension. And it's associated with some cancers as well, like breast and uterine cancer and cervical cancer, associated with fatty liver disease, with pulmonary disease, gallbladder, and some gynecologic problems, in addition to osteoarthritis and gout. So it has a lot of medical complications. And the most important thing is, of course, the cardiovascular disease, which is associated with obesity and hypertension. And we know that 1 in 3 adults will die from cardiovascular disease. So it is a fatal problem. What about hypertension? Hypertension actually is related to obesity. Excessive weight, we know it's causing hypertension, and also reducing weight will treat hypertension in some cases. And excessive body weight accounts for 26% of cases of hypertension in men and 28% in women. And this, the enhanced data showed that prevalence of hypertension among obese is actually 42%, and among overweight is around 27.8%. Whereas it's in the common population, it's around 15%. So it increases with overweight, and it further increases with obesity. And this Chicago Heart Association detection program, which enrolled, it's a very old study, but it showed early that there is a relationship and double effect between the obesity and hypertension, actually. It showed that the cardiovascular death was increased with those who have both hypertension and obesity, and it has also a stepwise fashion. When BMI increases with the hypertension, the events increase, and the events, we don't mean only events by the death, but also we mean by stroke and by other major cardiovascular events. And this is showing what's in a graph, what this study shows, that the more the weight, the blue one is with patients with no hypertension, the red one is with patients with hypertension. The more the weight, the highest the cardiovascular disease mortality, and it's much more when hypertension and obesity come together. So they have synergistic effect as well. Not only hypertension, but also with weight change, other diseases also increase, like the coronary heart disease, the cholelithiasis, and the type 2 diabetes, as well known. This is the same. And we know now that it's really one disease. At the center or at the corner of the pathogenesis of the disease is mainly insulin resistance. And this starts early here on the far end of the slide. There is genetic susceptibility associated with nutrition, overeating, obesity, and inactivity or sedentary lifestyle. When all of these come, that will lead to the metabolic syndrome, which is manifested by high blood pressure, high blood sugar, and abnormal lipid panel and obesity. And that, if there is no lifestyle changes at this stage, that will lead to impaired glucose tolerance, and that will go on to diabetes, and that will go on to complications of diabetes, and that will lead eventually to death. Metabolic syndrome, it's really not a disease. It's like a constellation of risk factors that we have to work on. But it's considered as an entity, recognized. And what it means is that we have to focus really on all the risk factors that the metabolic syndrome have. The cornerstone of metabolic syndrome is increased central weight circumference, which means central obesity. And it is usually associated with high fasting glucose, high triglyceride, low HDL, and high blood pressure. And at the center of this, as I mentioned, is the insulin resistance. There are many definitions of metabolic syndrome. However, the one with which the ATP define it is with 3 out of 5 components of those 5 components, which is high blood pressure more than 130/85, fasting glucose more than 110 milligram per deciliter, high triglyceride and low HDL, and of course high waist circumference. How obesity can lead to hypertension? Many actually theories and many mechanisms, which not all of them are well proven. However, I mean, there are some studies to support this. At the center, as we mentioned, is insulin resistance or hyperinsulinemia. Also, there is a role of leptin. There is a role of the sympathetic nervous system activity, which is increased, and renin-angiotensin-aldosterone system activity, which is also increased, and also increased salt sensitivity in most of the obese patients, which will lead to renal sodium reabsorption. How hyperinsulinemia will lead to hypertension? It will increase sympathetic activity, it will lead to volume expansion and endothelial dysfunction and upregulation of the angiotensin II receptors, and it will decrease cardiac natriuretic peptide, and it might be associated with genetic susceptibility. Also, in many obese patients, they have obstructive sleep apnea because of the obesity, and that per se might lead to hypertension, or it's one of the causes of secondary hypertension that Dr. Okurbi was talking about. And it has also some mechanisms playing a role in this, including activation of the sympathetic nervous system, enhanced aldosterone levels, and increased levels of endothelin by repeated episodes of hypoxia. What about leptin? Leptin increase in patients who are obese. It's actually it's increased because of the increased fat mass, and that leptin will go to the brain, and it will increase the feedback, leading to increased renal sympathetic activity, and that's the major role for causing hypertension. It will affect also the thermogenesis and the food intake, and it will also lead to vicious circle of continuous obesity. How do we treat obesity? So how do we treat obesity, and then how do we treat hypertension related to obesity? This lecture is not about treatment of obesity because it's about hypertension. However, I mean, we cannot emphasize less on lifestyle. This is something we have to advocate to ourselves, right, Dr. Shurafa? And to everybody else, and to patients, and to everybody. So lifestyle means diet, exercise, behavioral and behavioral changes, and then if failed, we go to medications, and then eventually some patients will need bariatric surgery. So if you want to go to this is actually was thinking about this dilemma. If you want to go to diet, then we have to classify food into 4 categories. Food which is good for you but tastes bad, or bad for you but tastes good, like yesterday's meal, or makes you fat and ugly, or eat it and die. So there is no good food. Of course, you always find a good food. This is a joke. And when we mention diet to patients, I mean, it doesn't mean that you deprive yourself of everything. That means to be really balanced in your diet. That means that you don't overeat, and also make good balance between the all nutrients of diets. As simple as that. It doesn't mean that you have to go into long fasting. It doesn't mean that you have to deprive yourself of everything. And you can use even traditional food, but make it more healthy. Less salt in the diet, less carbohydrate. But you can eat what you enjoy eating, really. But be cautious about the components, and be cautious about the amount. So this is, I think, the simplest advice that I always like to emphasize on with my patients. So low in calories, balanced in fats and carbohydrates, The DASH diet, there are many studies regarding DASH diet and hypertension. Mediterranean diet, also many studies about the usefulness of Mediterranean diet and its good effects on the cardiovascular outcome. Exercising at least, of course, 30 minutes per day for 5 times per week at least, and the behavioral modification. Of course, many studies showed that weight loss has positive effects on treating hypertension. In one meta-analysis, it showed that the reduction in hypertension in the systolic and diastolic will be around 4.4 millimeters mercury for each 5 kilograms weight loss. So this is why we always recommend weight loss for overweight patients. There are other studies showed that the mortality was lowest among patients who have BMI between 22.5 to 25 kilograms per meters square. There is one study which is more recent showed that actually the mortality was less in the slightly overweight patients. Okay, so obesity definitely is associated with the problems, but the overweight actually, there are conflicting data between what's the best really weight for you. Is it the ideal body weight, what we call ideal, or slightly overweight? I think the jury is still there. However, definitely reducing your weight or maintaining ideal body weight or stabilizing your weight is the key in improving the blood pressure. There are medical treatments also for obesity. However, many of them, they have side effects, and unfortunately, the weight loss that you gain with lifestyle and medications, also you lose it over time. For example, of the bariatric agents, many of them work on different mechanisms, orlistat, acarbose. Some of the medications which are used in diabetes treatment, they are used. Yeah, is something.
It's working.
شغال. Okay. They are. I don't think so. They are used in also obesity, like GLP-1. I don't think it's. Let's try this. Combination agents like also the combination between topiramate and phenetramine and between the natroloxone and poprobium. Is my voice, I think this is better now, yeah. Surgical treatment is, I think eventually some of your patients will need surgical treatment, either in morbidly obese patients or those who are obese with comorbidities. Some of them, we might recommend bariatric surgery eventually. And it is associated actually with remission of hypertension. Some studies show that the remission of hypertension in patients who undergo bariatric surgery actually is up to 38%. And yesterday we were talking about bariatric surgery now becoming actually a moda for physicians. So what about treatment of hypertension and obesity? The best treatment, because of the mechanism, is the ACE inhibitors or ARBs. And you can use calcium channel blockers as well, whereas beta blockers and thiazide are associated with dyslipidemia and increased diabetes. This is why it's not preferred unless there is compelling indication. But because of the salt retention in obese patients, you might need to give low-dose thiazide in those patients. So in summary, 2 billion of adults are overweight, 0.5 are obese. Excess body weight is accounting for approximately 26% of cases of hypertension. Metabolic syndrome is a constellation of risk factors that we have to work on. Insulin resistance, leptin, and sympathetic nervous system are playing the major role in obesity-related hypertension. We have to focus always in our advocacy on lifestyle modification. We might need to refer some patients to bariatric surgery. And remember, the best medications for obesity-related hypertension are ACE inhibitors or ARBs. And finally, this is a guy who brought a treadmill to exercise. So he's doing it the right way. He's exercising his dog while he's watching the TV and drinking big, large Pepsi. Thank you.
Thank you.